Thank you very much, Professor Tare. Thank you very much for inviting me to this great event. I'm delighted to be part of it. Today I'm going to talk about patients optimization. We all face these elderly patients with advanced knee osteoarthritis coming with diabetes, obesity, malnutrition, cardiovascular diseases, rheumatoid, anemia, urinary symptoms, a lot of medications. How to deal with that? So I'm going to briefly touch upon how to optimize these patient comorbidities, how to optimize their nutritional status, preoperative drug optimization, preoperative screening, how to deal with UTIs and smoking, and to end with patient education. And these are going to be my learning objectives. I based this presentation on the second international consensus meeting, ACAS, American Academy of Head and Knee Surgeons, NICE guidelines, and American College of Rheumatology. We need to start our care by the phrase patient-centered care. The good communication with the patient is essential and integral part. We need to share what's called informed decisions with them, and we need to manage their expectations, especially when it comes to the total knee, knowing that 20% of our patients might be at the end unhappy or unsatisfied. A lot of comorbidities, and we need to manage them on what we call multidisciplinary team approach. This is very, very essential for the best outcome. Let's start with the diabetes. We all know that they experience delayed wound healings, and those with poor glycemic control might encounter stroke, UTI, infection, death, increased risk, nearly threefolds of infection. But is this contraindication? Well, elective total joint arthroplasty should not be avoided, let me repeat, because of history of diabetes. We shouldn't refrain. However, we need to be very careful. We need to delay surgery till the glycated hemoglobin is less than 7, blood glucose level less than 140 before meals, and random less than 180. Surgery should be early in the day. Frequent blood sugar check post-operatively. What is the threshold? According to the consensus, below 7.5, please. But the magnitude of decrease is more relevant than crossing some arbitrary line. What is the most accurate marker? I get to know that just a few years ago after attending the consensus, which is the fructosamine. Now I ask for this, ask all my patients to do it routinely, because it reflects to be the accurate marker even more than the glycated. And the beauty about that, it has shorter half-life because it correlates with the glycated proteins. So it does reflect, sorry, the treatment effect within 1 or 2 weeks. When a patient comes with glycated hemoglobin, you need to tell him if it's high, go back and come back in 3 months. Whereas with this, it reflects the control within the previous 2 weeks. It might detect short-term hyperglycemic events, and the threshold is 292. That's the number. Obesity, we all face these patients, and we know that they are great host for infection, taking into consideration the longer surgical times, poorly vascularized soft tissue, high calorie but poor nutritional diet, etc. They have 4 to 10 folds of infection risk. Preoperative weight loss should be recommended in the morbidly obese and required in super obese as well. But there is conflicting evidence. Should we send our patient to bariatric surgery or not? There is a consensus opinion that we need to delay any patient for total joint arthroplasty more than 40 body mass index, especially if associated with other comorbidities. However, does bariatric surgery actually reduce the risk in patients with obesity? Well, the evidence is inconclusive and cannot be routinely recommended. What are the pros of bariatric surgery? Yes, it's not without the complications, but acceptable range of complications, and it's effective at reducing comorbidity burden, including diabetes, etc. However, the devil lies in the details. It might expose some patients to catabolic state, and I'm sure every single one in this room might have encountered one colleague who might have a catabolic state. It might result chronic malnourished states, osteopenia, osteoporosis, and anemia. So I usually follow this algorithm. More than 50 body mass index, it's risky. Weight management first, and 40 to 50 counseling for the risks, and we need to do some extra efforts like antibiotic dosing, extra skin preparation, superficial drains, etc. And 30 to 240 counseling. Do they really lose weight? Well, some studies showed they don't actually have weight loss after having the surgery. And those are quite challenging. More than 40 body mass index, destructive osteoarthritis of the hip and knee, wheelchair bound, unable to ambulate. Those are actually the poor patients that come to our clinics, and then we don't really know what to do with them. Nutritional optimization, the most important word here is albumin, among other things like lymphocyte count, transferrin, and zinc level. We need to optimize this before surgery. Anemia, we need also to supplement our patient with iron supplementation. We need to do to correct the anemia. And there might be a role for erythropoietin or hematological consultation. What is the transfusion level? We need to take into consideration that every unit increases the risk of infection by 9%. We usually take it as 7 to 8 gram per deciliter. However, in the elderly, we might increase the threshold a little bit, 8 to 9, especially if they are cardiac. And obviously, everyone in this room started to use the tranexamic acid as an effective strategy to lower blood transfusions, let it be intravenous or topical. But we need to be well aware about the renal impairment. We need to use only half the dose. I'm only concentrating on important aspects. And it's contraindicated in those who had coronary vascular stents, which are very common in Egypt within the previous 6 months, or DVT, PE, MI, ischemic stroke within the past 6 months as well. Hepatic conditions, please don't do them in child class B and C. I wouldn't touch these patients with total joint arthroplasty on elective basis. Cardiovascular conditions, we need to defer the surgery at least 12 months. And we need to have cardiological assessment and co-management whenever we manage them. We face a lot of rheumatoid condition, increasing the risk of PGI and complications. We need to well-time our arthroplasty, but most importantly, how are we going to manage their medications? Well, starting with the steroids, if the patient is taking less than 7.5 milligram or any dose for less than 3 weeks, that's fine. They don't need what's called stress dose. But if it's more than 20 milligrams, we need to inform our anesthetist because they might have adrenal insufficiency and we need to treat them with steroid dose therapy. I usually keep this table on my mobile and ask my patient, which medication are you on? Is it methotrexate? I could continue. Is it biologic agents? I need to stop, etc. So please keep that on your mobile. It's very, very important. Methotrexate is safe to continue, whereas anti-TNF is not safe to continue. It should be stopped for at least 1 cycle. Smoking, well, obviously it does increase the risk of PGI. We need to stop smoking for at least 1 month before surgery because it does delay primary wound healing. So at least 1 month is recommended. And for our cheeky patients, we know all of them, we need to check them using the serum creatinine levels. I didn't know that this is present, and it does predict the smoking within the last week. Intravenous drug abuse, obviously we need to stop at least, the patient should be clean at least 2 years before total joint arthroplasty. Likewise, alcohol abuse, it has to be stopped 1 month pre-operatively, otherwise they might have a lot of things in addition to that they might have associated liver disease and malnutrition. We need to screen all our patients for MRSA. There is enough evidence that this is cost-effective means, and we might choose intranasal myoperisone to decolonize them. However, beware of the resistant strains. To finish my talk with the UTI, all patients should be asked about symptoms. And we need to obtain routine urine analysis only on those who have some symptoms like dysuria, urgency, and frequency. And, but no routine otherwise in those asymptomatic patients. Okay, if the patient comes with, sorry, it's just 1 minute, please. If the patient comes with UTI before surgery, would I operate on them? Absolutely not. We need to stop everything for the operation. We need to refer to urology, and then, oh, sorry, it doesn't. And then I would refer them to the urology to treat them at least 10 days with antibiotics, 5 to 10 days, and then I'd repeat the urine culture and then take them to theater. Do we need to catheterize every single patient? Absolutely not. We might use what we call intermittent catheterization, or at the end of our surgery, just to empty the bladder. And if I'm going to use a urinary catheter, I would only hold it for 48 hours. And even in the spinal anesthesia, not necessarily to have this catheter. And we need to educate them. We need to teach them some exercises before the surgery to be able to improve the outcome and assist in early recovery of physical function. Finally, I tried to touch base upon how to optimize the medical comorbidities, drug optimization, we need all to keep the table, how to manage obesity, anemia, preoperative screening, and patient education. Thank you very much.